So I'm here today to speak about quantitative research methods, and in particular highlight some of the similarities and differences between randomized clinical trials and observational studies. So I'm going to start with a brief description of the goals of quantitative research, and then compare and contrast study designs for RCTs and observational studies. And I'm going to highlight some of these differences with examples of some of my own past and current research projects. And for this presentation, a key reference for students would be the online textbook called the Population Health Primer, which was developed by the Association of Faculties of Medicine of Canada. And the web link to this online textbook is there at the bottom of the page. So my research is really focused on HIV, and my work in Canada is primarily, most recently been on HIV epidemiology and population health research related to men who have sex with men. I've also done research on clinical outcomes of HIV-infected individuals in BC on HIV treatment using the HIV Drug Treatment Program database. And a lot of this work is done in partnership with health authorities and community-based organizations in BC. In addition to that, I also do some research in Uganda, primarily related to HIV health services. And this I do in partnership with a local non-governmental organization called the AIDS Support Organization, as well as international research partners such as the US CDC and the Medical Research Council of the United Kingdom. So quantitative research is really based on a foundation of counting and mathematical analysis. It uses study designs which seek to minimize the role of human judgment and bias in collecting and interpreting evidence. Quantitative methods look for statistical associations between variables or for differences in patterns of health between one population and another. So the potential objectives for a quantitative research project would be, for example, to describe differences in health status between two or more study populations, to evaluate different healthcare interventions, as well as to look for causal factors that influence health status. And of course, there's many other types of objectives that you can have, but these are just a few of the more common ones. So, but irrespective of your objectives, all studies should start with a research question that addresses what the investigator would like to know. And then the research question, along with the proposed hypothesis, the data that you're collecting, and the resources available will all determine the study design. And you can often use different study designs to answer the same research question. So here, a usual example of a research question for what we term analytic studies, which I'll describe in a bit more detail later, is, for example, in a population of study population is a predictor variable or explanatory variable associated with a particular outcome variable. And a couple examples of this are in a population of injection drug users with HIV infection, is ART use or antiretroviral therapy use associated with fewer opportunistic infections? Or in a population of pediatric emergency patients, are speed humps associated with decreased odds of trauma? So before I get into study designs, just to tell you, there's actually a number of different ways of classifying or organizing study design, and I'm going to show you a couple of examples here. So I like to think of quantitative studies really dividing them into two types: descriptive studies, which generally don't test a specific hypothesis, but really are, as the title might imply, describing a situation. And examples of these include case studies, case series, and surveys. Descriptive studies can be compared or contrasted with analytic studies where you are trying to test a specific hypothesis. And the most common, so the study designs for analytic studies are generally randomized controlled trials, also known as experiments, observational studies, of which there are several different groups, as well as meta-analyses and systematic reviews that try to collate results of similar studies to arrive at sort of an overall estimate of effect for a particular outcome. And as I mentioned, analytic studies specifically test a hypothesis. So I like to think of dividing study designs into these two large groups, descriptive studies and analytic studies. And within analytic studies, you can further subdivide study design into experimental and observational studies. And then for observational studies, the three most common study designs that are used are cohort studies, case control studies, and cross-sectional studies. Now, from the population health primer, which I gave you the reference for earlier, they prefer to sort of categorize study designs in this manner. So they start, first of all, with the question, did the investigator assign exposures? And if the answer is yes, then they categorize that as an experimental study. And if no, then it's categorized as an observational study. Then they ask the question, are you testing a hypothesis under observational studies? If you are, you have an analytic study, and if not, you have a descriptive study. And then further down below, analytic studies are the same three groups: cohort, case control, and cross-sectional. And then further within the experimental study design, they ask, is there random allocation into groups? And if there is, then this is a randomized controlled trial. And if not, it's a non-randomized experimental study design, which I'll list a few later. So really, we're talking about the same overall types of study design. It's just about how you conceptualize the classification of them. So back to analytic studies. So these studies where you're testing a hypothesis describe the relationship between one or more explanatory variables, or sometimes called predictor variables, and a particular outcome variable. So as I mentioned, there's experiments such as controlled trials where the investigator directly manipulates the explanatory variables or assigns people exposure to a particular intervention. And then observational studies where investigators just observe the effect of explanatory variables on an outcome variable, but don't actually determine the exposures to the explanatory variables. So I mentioned the three types of, or subtypes of observational studies, which I'll get to after we go through experiments or randomized trials. So experiments, as I mentioned, the investigator controls the predictor or the explanatory variable, which is usually an intervention or a treatment. And because of this, it has a major advantage over observational studies in terms of their ability to demonstrate causality. And that means that essentially, with a randomized trial, you can be certain or reasonably confident that the only difference between the two groups is the explanatory variable which you've assigned to one group and not the other. And this allows for controls for potential confounding. That is, things that can affect the outcome that are not your primary variable of interest. And may sort of affect both the exposure category or the exposure variable and the outcome variable. And the other benefit of randomization is that it doesn't just control for confounding variables that you can actually potentially think about, but it can also likely controls for unmeasured confounders because of the randomization process. However, randomized trials or experiments are really only appropriate for so-called mature research questions, where you've got kind of a good sort of scientific basis for determining whether something is worthwhile to study in an RCT. So, as I mentioned, randomized controlled trials are, kind of the gold standard for experimental study design, but there are actually a number of other non-randomized study designs, which include controlled clinical trials without randomization, factorial design, match pairs randomization, group or cluster randomization, as well as some other designs called time series or crossover designs. I'm not going to get into any details about those, but those are other types of experimental study designs that you may see in the scientific literature and textbooks. So here's a schematic of what a randomized trial looks like. You start with your study sample and you randomly assign, for example, in a study of a particular treatment, you randomly assign participants either the treatment or the placebo, and then you follow these individuals into the future and determine who becomes sick and who becomes well. And this allows you to see the effect of your treatment on the disease or condition of which you're interested in. So the steps in a randomized clinical trial. First of all, a researcher formally states what the hypothesis is that you're going to be testing. Usually this is done in terms of writing out a study protocol, or and often is needed as part of a funding proposal to get your study funded. The researcher then selects people eligible for the treatment. The sample is divided into two groups through a random allocation procedure, and one group, which is the experimental or intervention group, is given the intervention while the control group, is not. And then the outcomes of interest are recorded over time, and the results are compared between the two groups. So as I mentioned, random allocation helps to control for confounding, and it also includes confounding factors which are unknown. However, there are also some limitations with randomized clinical trials. So it's really best used for discrete interventions such as new medications or procedures. However, it can also be used for surgical procedures, behavioral interventions, and other types of interventions, although often it's more difficult to actually blind participants to the intervention in those circumstances. And yeah, more complex interventions are become increasingly more difficult to study through an RCT, but again, not impossible. However, a lot of higher level interventions like health or government policies are not really possible to study through an RCT because you're not usually able to randomly assign or even or have much control over particular government policies in the context of an experiment. And the other limiting factor is really cost. Randomized clinical trials tend to cost a lot more than other study designs for a number of reasons. So I can maybe walk you through an example of a randomized clinical trial that I was involved in starting probably about 10 years ago. So this was something called the Home-Based AIDS Care Project, which was a study that was done in Uganda. So the rationale for this study was that early in the expansion of antiretroviral therapy in sub-Saharan Africa, there was a concern that a lack of available laboratory monitoring would result in large numbers of patients becoming resistant to the antiretroviral medications, becoming ill, and dying. And so the Home-Based AIDS Care Project, or HBAC, was a 3-arm randomized clinical trial examining different strategies for monitoring patients receiving antiretroviral therapy in this context. So, there were some ethical considerations which often arise in the context of doing an RCT. At the time, some were arguing that it wasn't ethical to provide antiretroviral therapy without the expensive laboratory monitoring, which is routinely used as an adjunct to HIV treatment in industrialized countries. However, other people, were arguing that it was actually not ethical to provide such monitoring, as it would divert funds away from paying for more medications and staff, which could keep more people living with HIV alive. And in some respects, sort of this tension between, well, it's not ethical to do the study and it's not ethical not to do the study suggests that it was probably a good opportunity for studying something through an RCT design. And that's typically known as kind of clinical equipoise. You're not really certain that what you're studying is going to be a benefit, but you've got good reason to think that it might be. So this was the paper that came out of the study, which was published in the British Medical Journal in 2011. So our hypothesis from this study was that clinical outcomes amongst HIV-positive individuals receiving antiretroviral therapy without access to any laboratory monitoring will not be significantly different from individuals receiving ART with quarterly CD4 cell counts. So that was one of the other types of monitoring, or quarterly CD4 cell counts and an HIV viral load measurement. And I'll show you a schematic in a couple slides that will show you how this was done, or sorry, this slide. So what we had was a so-called open cohort of 1,000 people living with HIV and AIDS, or living with HIV. In arm C, I guess, is kind of our comparator arm. So these individuals received weekly home visits for clinical monitoring, as well as ART drug delivery. In arm B, the individuals received weekly home visits for clinical monitoring and drug delivery, plus they had CD4 cell counts measured every 3 months. And then in arm A, participants received weekly home visits, quarterly CD4 cell counts, and quarterly viral load tests, which is really more like the standard of care in industrialized countries. And then we were looking for measuring the outcome of severe morbidity, which were in fact AIDS-defining illnesses, and mortality after 3 years of follow-up. So as I mentioned, this study was done in Uganda, in East Africa, and actually it was conducted in 2 districts on the eastern border of Uganda with Kenya. And it was implemented in partnership with the U.S. Centers for Disease Control, as well as a local NGO, the AIDS Support Organization. So to be eligible for this study, individuals had to have already have a WHO clinical stage 3 or 4 illness, excluding isolated pulmonary tuberculosis, or a CD4 cell count of less than 250 cells per microliter. And this was kind of in keeping with ART eligibility criteria at the time. And for our analysis, we actually excluded people that had reported any previous antiretroviral therapy use. They were actually allowed to be included in this study because we felt that if we made that an exclusion criteria, we'd probably not get honest answers for whether people had used antiretroviral therapy before, because it's very difficult to access when the study was started. So we allowed them to enroll in the study, but then we excluded them from the analysis. And we conducted, as is common in randomized trial, the primary analysis was something called an intention to treat analysis, which includes analyzing all participants' data from the date of their enrollment or the date of the randomization. And then we also conducted something called a per protocol analysis, which was looking at the data after the first laboratory data became available after 3 months, since you wouldn't expect to see any effect of the intervention until sort of the first laboratory results were made available. But the primary outcome was, as for most randomized trial, was the intention to treat. So we ended up randomizing over 1,100 individuals, of whom just under 1,100 started ART. The median CD4 cell count was 128 cells per microliter, which is quite low, so indicating this was a population with fairly advanced HIV disease. In follow-up, there were 126 deaths, or 11.2% of study subjects, and most of these, nearly 50%, were in the first 3 months. Furthermore, there were another 148 episodes of AIDS-defining illnesses, and again, these were the majority of these were confined to the first 3 months. Overall, treatment success treatment effect was very good. We only ever had about 6% of individuals with 2 viral load measurements over 500 copies per milliliter, so that's excellent. And we had very few people who needed to be switched to second-line drugs even after the end of 3 years of follow-up. So, and this is the trial profile, which kind of shows you the 3 arms of the study. So this is the viral load arm, the CD4 only arm, and the clinical arm. And you can kind of see we start with approximately 385 people in each arm. We excluded approximately the same number of people from the analysis in each arm. So that gives us about 370 participants involved in the intention to treat, and about 350 individuals that were included in the per protocol analysis. So this was looking at our study results. So this is what's called a Kaplan-Meier curve, looking at survival over time, survival or a new opportunistic infection. So these people at the end here have not either died or had a new opportunistic infection. So you can see that, close to 85% of people don't achieve one of these outcomes by the end of kind of 3.5 years of follow-up, or 3 years of follow-up here. And you can kind of see that the viral load and the CD4 arms are very similar, and the clinical arm has a somewhat lower survival, so more people either dying or having new opportunistic infections. And when we did the main analysis, which was what's called a Cox proportional hazards analysis, included some adjustments for factors that we knew were associated with mortality or new opportunistic infections. We found that arm C compared to arm B, so the clinical arm compared to the CD4 arm, that there was an increased hazard of new opportunistic infections or death, about 1.5 hazard ratio, with one meaning that there was actually no association, so there was an increased association of risk for these outcomes in arm C. And when we compared arm C to arm A, which was the viral load and CD4 monitoring arm, we also saw an increase in risk for new opportunistic infections or death. And while there was a slight increase comparing arm B to arm A here, this was not statistically significant. So the conclusions from this study, so our primary hypothesis was disproven. So it did look that there was a reduced risk of new opportunistic infections or death with both the laboratory monitoring arms in comparison to the clinical monitoring arm alone. And we did have this secondary finding that we didn't actually find any difference between those who had regular viral load monitoring versus those who had CD4 cell counts alone. Okay, so back to observational studies. Here are the three main types again, which I've described before. So first of all, so cross-sectional studies, these are studies that describe a relationship between an explanatory variable and an outcome variable at a single point in time. So these things are measured at the same time. And it has the advantage of being inexpensive and relatively easy to implement. And of course, because you're only collecting data at one point, you don't lose participants to follow-up. However, you can't really distinguish cause and effect relationships because you're measuring both of these outcomes and the explanatory variable at the same time, so you don't really know which came first. And it's also not very well suited for rare outcomes unless you have a very large sample size. And when you're analyzing cross-sectional studies, you usually end up with something called a risk ratio or a prevalence ratio. And here's the formula for calculating these. So essentially, you're looking to see whether the outcome variable at the time of the study is present or absent, and whether the predictor variable or the explanatory variable at the time of the study is also present or absent. And you'll see this similar kind of analytic approach to other studies in subsequent slides. Okay, so the second type of observational study is what's called a case control study, and it's used to study rare outcomes. And because cases and case control can establish a temporal relationship between explanatory outcomes and variables, it avoids the problem of what we call effect-cause relationship that we couldn't distinguish from in the in the cross-sectional study. So these are always done with kind of looking back in time, but measuring outcomes and exposures, or asking about outcomes and exposures in the present. So what you do is you specifically select cases who are subjects who are identified with the outcome at your particular time. So for instance, lung cancer. So you go and you search for a number of lung cancer patients, and then you also select a number of control subjects who are known not to have lung cancer at the time of the study. And then you ask people questions, or you do some measurements to determine exposure to explanatory variables in the past. So for example, you can ask people who's with lung cancer if they smoked in the past, and this was actually the study design that first showed the relationship between cigarette smoking and lung cancer. And so this is able to examine the relationship between explanatory variables or variable in the past and the outcome in the present in both groups. So here's just a schematic showing that. So here's the present. You have people with the outcome and people without the outcome, and then you're asking them for past exposures, whether they were present or absent, and compare the two. The way you compare them is by calculating something called an odds ratio. So you start out with the same 4x4 table, but you end up using the cross product of this, which is A times C times B times D. The odds ratio is calculated from a case control study, can approximate the relative risk, but it only works when the disease is rare. That is, if you have less than 5% of people in your sample having the disease. Oh, which I should mention is not usually the case, because you're actually, in a case control study, you're actually selecting people on the basis of the disease, and you usually take either an equal number of cases and controls, or you may take up to 4 cases per control, in which case the disease is usually about 20% of your study sample. So you have to be cautious that if you see a very high odds ratio, it probably doesn't reflect the actual relative risk. It's probably an overestimate in most circumstances. Okay, so for case control studies, you can't determine the incidence or prevalence of the outcome in the population, because you're actually determining the prevalence of the outcome by the number of cases and controls that you select. And it's prone to both sampling bias, especially what's called recall bias, and confounding. So recall bias is where if somebody has a disease in the present, they're probably more likely to think about things that they had in the past that may have caused their disease. And as well as there's a lot of more potential for confounding in this type of study design, really, than any other type of even observational study design, certainly far more than an experiment or RCT. So relative risk is approximated by the odds ratio, but which can give you some measure of risk, but it shouldn't be interpreted as the relative risk in a case control study. Okay, so cohort studies are comparative observational studies in which the subjects are grouped by their exposure status. So in case control, we were thinking about their outcome status at the time of the study. This is you're grouping people on the basis of their exposure status. So here you might find, to use the lung cancer example, you might group people by whether they're currently smoking or not smoking, and then follow them into the future to see if they develop lung cancer. So often it has both descriptive components, such as the incidence of a certain outcome, as well as an analytic component, which analyzes associations between explanatory variables and outcome variables. So the subjects, the exposed and unexposed to the explanatory variable or the risk factor, are followed forward in time to determine if one or more new outcomes or diseases occur. The subjects should not have had the outcome variable on entry to the study, and the rates of disease incidence amongst the exposed and unexposed groups are determined and compared. So these are the elements of a cohort study. So first of all, you select a sample of study participants from a particular population. You measure the explanatory variable in the sample, and then you follow the population for a period of time, and then measure the outcome variable and compare usually the incidence of the outcome variable in the two groups at the end of the study. So here's using the smoking example. So you have a group of interest, so a group of people that are smokers and a group of people who are non-smokers. In contrast to a experiment, you're not assigning who smokes or who doesn't smoke. You're just observing groups of people that choose to have these exposures. You follow them over time, both groups, and then you compare the outcomes in each of the two studies. So, and there's actually, we've mostly described what's called a prospective cohort study, where you enroll people and you follow them forward in time. However, there's also a possibility of doing something called a retrospective cohort study, where you can, often using clinical databases or administrative databases, you can actually go back in time to look at exposures in the past and then determine in the present who actually developed the outcome that you're interested in. And in fact, this database of people on HIV treatment in the province of British Columbia is in fact kind of an ongoing retrospective cohort study, because we can go back and look at clinical data from individuals back in, as far back as the early 90s, and then follow them forward in time to see whether they developed illness or died or, developed drug resistance, those kind of outcomes. So when you're analyzing cohort studies, the main outcome that you're usually measuring is incident rate, and you usually try and get an incident rate ratio to compare between those people who have the exposure or the explanatory variable of interest or the predictor variable, and those people that don't. So you follow people forward in time, you determine whether the outcome is present at the end of the study, the A's and the C's, and you're following these people, and then you compare the incidence rate of the disease over the time period. Although it's actually usually calculated in something in terms of a person years of follow-up, so it includes both the number of people you're following as well as the time of follow-up. And the main outcome measure you're mentioning, that you're comparing the two groups with, is something called an incidence rate ratio. So the strengths of a cohort study are that the predictor variable or the explanatory variable was present before the outcome variable occurred, particularly in prospective cohorts where you can measure those well before the outcome measurement happens. And you can directly measure incidence of a disease outcome. As well, you can actually study multiple outcomes of a single exposure. And, as I mentioned in our studies of HIV positive patients receiving antiretroviral therapy in British Columbia, we can study mortality, we can study, new AIDS diagnoses, we can study drug resistance or, virologic suppression. There's a number of different outcomes that you can look at. However, weaknesses of cohort studies. They're often expensive and inefficient for studying rare outcomes. It's in the example of following cigarette smokers, you would actually have to follow cigarette smokers for a very long time before, many of them actually develop lung cancer, and certainly to be able to determine, whether cigarette smoking was associated with lung cancer. That's why most of the initial study designs for determining the association with cigarette smoking and lung cancer were in fact case control studies. And as I mentioned, you often need a long follow-up period or a very large population, and this issue of loss to follow-up can really affect the validity of your findings. The caveat around being expensive and inefficient, that's generally true for prospective cohort studies, but increasingly researchers are using, as I mentioned, kind of clinical or administrative databases to study large populations who can be followed over time relatively inexpensively. So retrospective cohort studies can actually be a fairly efficient study design as opposed to prospective cohorts. So here's an example, not of a cohort study, but a cross-sectional study that I was involved in. And this was looking at disclosure of same-sex sexual activity to healthcare providers amongst men who have sex with men in Vancouver, Canada. So this was actually an analysis from a cross-sectional study or a survey called the Man Count study, which was part of a series of cross-sectional surveys funded by the Public Health Agency of Canada to examine HIV, hepatitis C, and other STI prevalence amongst men who have sex with men across Canada. So this was kind of the Vancouver version of this series of surveys. So we recruited participants from August 2008 to February 2009 at venues and events that catered to gay and bisexual men. And we asked participants who were aged more than 18 years of age to complete a questionnaire, and they also provided a dried blood spot for HIV, hepatitis C, and syphilis testing. And participants were given $10 for study participation. And then in this analysis, we wanted to analyze the association of several explanatory variables with having disclosed the participants have male sex partners to their regular healthcare provider. So that was the outcome of the study here. So this kind of shows you the general ethnicity of study participants. The median age was 33 years. Vast majority had completed high school, and about 81% self-identified as gay or homosexual, and 11% bisexual, with smaller minorities identifying as other sexual orientations. And what we found is that of the HIV negative individuals, 77% of these participants said that they had actually disclosed that they had male sex partners to their healthcare provider. We're primarily interested in this because disclosure of having male sex partners for men would probably be the first step in being offered an HIV test for these men if it was based solely on the risk of being men who have sex with men. So this is kind of what's called a multivariate logistic regression model, factors associated with being out to your healthcare provider. So you'll note here that we're actually using an odds ratio rather than the risk ratio that I described for use with cross-sectional studies. The main reason for this is that if you use this logistic regression procedure, you can actually study multiple explanatory variables at the same time, which isn't possible with the risk ratio. So even if you're using that study design, you can still use odds. And this is a model that is sort of adjusted for all other, known confounders of things variables that we measured in the survey, and the factors where the confidence intervals do not cross 1 are significantly associated with the outcome. So if you look at this, we found that individuals whose first language was other than English had a reduced risk of disclosing their same-sex sexual status to their healthcare providers. Age was not associated with disclosure, and neither was education status. So even though the odds ratio here is below 1, you can see that the confidence intervals cross 1. Certainly if people had higher income, and here income was not particularly high, higher than $20,000 per year, you can see that that also was associated with people being more likely to disclose their same-sex sexual behavior. And as well, if they had sexual orientations other than gay, so that included bisexual men, as well as men that identified as straight or queer or two-spirited, those other sexual orientations were less likely to come out to their healthcare provider. And you can also see that that having a large number of sexual partners, 10 or more, also made it more likely that individuals would disclose their same-sex sexual orientation. And interestingly, we didn't actually see any difference in sort of risky sex or self-assessed likelihood of acquiring HIV in their lifetime between those people that disclosed their sexual orientation to their healthcare providers with those who didn't. So, just in conclusion, quantitative research uses many different study designs, many of which you can use to answer the same research question. But it's important to understand the strengths and limitations of each when you're reading research studies, and in particular when you're designing your own research. And here again is kind of this hierarchical model of how to classify the different study designs. But I also encourage you to look at the online textbook to see what they have, how they describe it there as well. I just wanted to finish by acknowledging a colleague of mine, George Rutherford from UCSF, and this writing workshop series that they give, where I was able to borrow a number of the slides for this presentation. Well, that's it. Thank you very much.